Good afternoon to all the aspirants present here. It's the second class of Genito-Urinary Medicine and AIDS, and the speaker that we have here is Dr. Anand Joshi, consultant intensivist and physician at Gamman Hospital, Hyderabad. So you may take over. Thank you.
Thank you, Fatma, and welcome you all. So this is the second part of our ongoing MRCP classes for the genito-urinary infections. Yesterday, we have briefly overviewed the common genito-urinary infection, in particular gonococcal and non-gonococcal urethritis. There are quite a few there, which I recommend you guys should have a cursory overlook. This is more in terms of when you're doing history taking, you need to keep those differentials in mind. Detailing into every infection was out of scope of yesterday's talk. One of the important sexually transmitted infections worldwide, and even for that matter, wherever you are, whichever world you are practicing, is going to be retroviral disease or HIV/AIDS. Now, it is a very, very vast thing. Early, I remember my whole of my general medicine, I would say practically, I have learned on HIV patients because they are like so immunosuppressed and immunocompromised that we tend to learn lot many infections, lot many physiology, lot many pathology on these people, and it is very important topic also from exam point of view. So AIDS, acquired immunodeficiency syndrome, was first described in 1981, and then the virus causing AIDS was discovered in 1984. Since then, there has been quite a significant impact with more than 20 million deaths. More than 33 million people are living with HIV, more common still in Sub-Sahara and Africa. With the period of time and over last 20-25 years, or more than 30 years now, there has been stabilization in some regions. However, there are still few rising rates in the Eastern Europe, Central Asia. It is very sad to know statistically, or knowing the data, that almost 15-year-olds are having almost a prevalence of 33%. And these people end up dying for the various reasons, including late presentation and inappropriate treatment and therapies. A lot of social, behavioral, cultural, and political factors affect. Heart, that is highly effective antiretroviral therapy, has managed to reduce the mortality, but however, the transmission is still occurring. And to be very honest, out of all the people who are affected, only a quarter of them who need heart are on the treatment. So a lot of people have no accessibility to a treatment. We are in a very good shape. We are in, maybe India is called as developing country, but now we do have access to lot many treatment, and we are lucky in this part. But almost quarter of people who are in Sahara, Sub-Sahara desert, they don't have access to this therapy. The problem, another problem which arises with no access or no treatment, is that these people remains infectious, and for every two infections which we have, one, if even if you're treating one person of it, they have already transmitted to the people, and it is estimated that one person getting treated every time that two new infections are being transmitted. So that's a sad part. While you're giving the MRCP exam, you need to know the local data on that. In UK, per se. There has been falling death threats. However, there has been continued new infection. Now, this is something which you need to. It's surprising. If the deaths are falling, that means they are manageable. That means we cannot eradicate. At the same time, if the new infections are coming, then there is a lot of social, educational issues going on. Heterosexual and homosexual individuals from sub-Sahara are the largest affected group, and even though they are the new migrants, they do carry with them these problems. 30% of the UK diagnosis comes in the women. So again, there is something concerning from the first world country. Um, Good or bad part of it is the mortality has come down. However, we do have an aging population with HIV. Almost 25% in UK remains undiagnosed. And because of that, the presentation is many times very late. And this late diagnosis is related to the increased morbidity and the mortality. So this actually emphasizes the importance of wider testing in high prevalence areas. So even if you're in a first world country or in the UK, there will be area where there will be high prevalence statistically and epidemiologically. And then for even though patient are symptomatic, asymptomatic, it the importance of wider testing is emphasized here, because if they come late or if there is a late diagnosis, then it adds on to the mortality and morbidity. All of you know the routes of transmissions. Most common is a sexual intercourse, particularly vaginal or anal. In heterosexual transmission is the most common worldwide. Male uh, male sex male MSM is very predominant in UK, and this is along with the sexually transmitted infection. So those people who are victim, or those who are um, already having these sexually transmitted infections, these people are at the increased risk of transmitting the HIV. The second mode of transmission is mother to child, that is a vertical transmission, and that happens through either a transplacental or at the time of birth or with the breastfeeding. Now, almost 15 to 40% of the babies affected without intervention, 15 to 40% of the babies without intervention, it's affected through transplacental infection. And these transplacental infections are associated with advanced disease in mother, high maternal viral load, prolonged labor, and premature rupture of membrane and chorioamnionitis. Along with that, if the mother is breastfeeding, then it doubles the risk of transmissions. However, like these things are more common and known uh, when there is no intervention. But the intervent with the current guidelines and the proper use of antiretroviral agents and avoidance of breastfeeding has been effective in the developed countries, including UK, and the numbers of and the number of babies with active HIV infections are falling down. Other routes of transmission is with the contaminated blood and blood products. Now, with the new screening laws which has been implemented across the world, these incidents are coming down. However, still, in even in a small percentage, these routes are still prevalent. IV drug use, needle stick injuries are another common. Healthcare workers, we are at very risk, and with the proper implementation, though, the risk has come down to 0.3%. It is important for us to know and to educate our surrounding and those who are non-medicos, and let them know that there is no spread through social contact or insects bite or the mosquito bite or blood sucking insect, or use or sharing of the things, glass, or having food in the same thing, same plate. These things do not transmit the HIV. There are a lot of misconception, and hence I have to emphasize on it. Now let's look at the virus. So it's a Retroviridae family, lentivirus group. There are two main viruses known, HIV-1 and HIV-2. HIV-1 is more virulent and widespread globally, and HIV-2 is there mainly in West Africa. Now, if you remember this, or if you try to kind of keep it in your back of your mind, this structure, it becomes very easy for you to understand the antiretroviral therapies and where do they act, etc. So you can see this is a like any virus, you can imagine it like a cricket ball kind of thing, and this whole outer cover is made up of lipopolysaccharide or lipid layer. In between the lipid layer, those mushrooming like things which are coming, the green and the top, they are GP41 and GP120 proteins. Together, they are called as 100 and GP160. These form the envelope. Now, inside the lining is P17 matrix, and inside that, the pink color with surrounding beads is the core. Now, this core has a single stranded RNA, and the green color which has is a reverse transcriptase. Now, this is a very important enzyme because this is the one which embeds, or because of this enzyme, the RNA gets into a DNA, and then that DNA gets embedded into the human DNA genome. So this becomes an important target for the therapy. The small blue ball are the proteases. They are responsible for reforming this outer cover and other protein components, and they also become an important target for treatment. Please, anybody having any questions, please stop and ask. We'll appreciate that. Now, with advancement in the science, we have now known, and we will be focusing or talking mainly on the HIV-1. So HIV-1, there has been a lot of genetic diversity. Now, why we need to know the genetic diversity? Because many a times some targeted therapies may not work, or suddenly may stop working, in which case you may have to look into the genetic group. The most common and the most major group is M group, and then you have NOP. They have further subtypes from A to K. It forms in the recirculating recombinant forms, CRFs, and subtype B is more common in Europe and North Africa. Then other groups, we have group N, most commonly in the West Central Africa. Then we have group O, which more in Cameroon, and then we have a group P. Now, how does this HIV enters into the body and cause the disease or cause the AIDS? So entry is enters the body, and it enters the immune system, particularly targets the CD4 plus T cells. And these CD4 T cells have got CCR5 co-receptor, which I will show you in the next figure. Early infection occurs in the gut, and as we know, the whole gut wall has got a lot of submucosal lymphoid tissue, and it attacks and starts destroying these CD4 cells, and that's when it depletes the immunity at the gut, and that's why their presentation with like abdominal pain and diarrhea. The virus per se has a half life of about 6 hours, and however, once it enters into the cell, the multiple virus keeps on multiplying and getting produced more and more, and then it literally bursts opens the CD4 count, causing the cell death, that is CD4 cell death, and then release of lot many viruses, which will again go further and look for other CD4 cells and enter into their cells. The viral turnover is very high, almost 10 raised to 8 to 10 raised to 9 viruses per day. And this leads this rapid destruction of the CD4 cells and acquiring of the new CD4 cells, and then again destroying them, leads to their depletion and hence the immune dysfunction. So this is the pictures presentation of what I said. So as you see here on the one, you have this HIV virus with GP120 and GP41, which binds to the CD4 receptor of the lymphocyte. Along with that, there are also co-receptors, which we talked about, like CCR5. Now, why we need to know about the co-receptor? Because again, it becomes a therapeutic target for the treatment. So once this outer envelope gets attached, these receptors get fused with the outer wall and releases the core. And as it releases the core, it opens up, and the RNA gets released into the cytoplasm. Now, this mRNA, in the presence of the reverse transcriptase, get into a DS double-stranded DNA. Copies are formed from the RNA template, which again gets embedded inside the human DNA. This human DNA, as we have mitosis, meiosis going on, as it gets divided, that we call it as a transcription, it causes further release of mRNA and mRNA genomes. Now, this mRNA, with remember we have those protease, which are the proteins or the enzymes sitting inside the virus. These protease, along with the other structured proteins, with the help of reverse transcriptase, again leads to the formation of the viruses. So this viral capsid assembly, so the inner core is formed, and as this inner core forms and it buds out through the lymphocyte, and this is called as budding, and the virions are released. These virions gets matured and then again enters into the new cells. So this is why we need to know this, is because this 1, 2, 3, 4, and 5, which you are looking at the screen, are the 6 are the potential therapeutic targets, and hence you need to know. So if you know these things, you know where the things are happening. Now, that was what the virus does to the body. And with that, as the CD4 tells, and as with any other virus, it stimulates the immunity. Now, immunity has a on switch and off switch. It gets on switch when the virus is entered. But here, the virus is making house inside the immune cells, CD4 plus cells. And then it bursts open and keeps circulating and stimulating the immunity. So a state of chronic inflammation gets established in the body. And this interaction causes this chronic inflammatory state. And chronic inflammation now occurs from HIV per se. Now, along with this, as the immunity goes up and down, or rather declines, other opportunistic infections starts bothering, especially the CMV and all the gut translocating bacteria. So all these things, when they enter into our immune system and with their lipopolysaccharide and their pro-inflammatory stimulation or triggers, this keeps the body in a perpetual state of inflammation. And this resultant cytokine release and the cytokine dysregulation plays an important role in the end organ damage. So you can say that what happened, why does the patient, if the patient doesn't get secondary infection, assuming the patient is in extremely sterile case and have no secondary infection, will the patient die? Yes, he will die because there is a perpetual inflammation going on, perpetual cytokine things are going on. We normally see these things in the intensive care in acute phase where there is a large cytokine release and then the patient gets into that end organ damage, and then we call it as a sepsis induced multi-organ dysfunction. The similar thing happens, but it happens in a slow motion here. The cytokines are released and there is a continuous immunity stimulation, and then there is again the systemic inflammatory response, and then it has a counter regulatory, and this circle goes on and ends up in a end organ damage. Not to forget, during this all this chronic inflammation going on, opportunistic inflammation again come and again stimulate the other way around.